Preparing for PACES is not easy. When I was preparing, I found it very difficult to understand the structure of the exam and the grading and the different skills and the stations and how to prepare for this exam that's probably the most difficult exam that you'll take if you are in internal medicine. So I've decided to make this video. If you're starting to prepare and you don't know where to start and the exam it's a bit confusing, then you're in the right place. We'll go in depth into the structure of the exam, the scoring system, each skills, each station, and we'll go over the exam results from previous diets that are published by MRCP UK to really understand the scoring system. And then we'll go over a step-by-step guide on how I prepared and how I would propose that you could prepare for this exam as well. I personally used a lot of resources and a lot of people helped me along the way. And I just want to give back and have one in-depth video where we go over everything you need for the PACES exam. I have another video that's around 15 minutes. If you're just thinking about PACES and you're not sure if you're going to go ahead with it or not, it's going to be on a pop-up on the video, so check that video out. But if you're determined and you want to start preparation, then this is the video that you want to watch. All right, so let's get into it. PACES is one of the toughest exams for a medic. However, don't let that put you off. It's very achievable. You just need the right preparation, and more importantly, you need the right mindset for it. So we'll cover everything from the structure to the scoring and how to prepare in depth. So eligibility for the exam, you must pass MRCP Part 1 or both Part 1 and Part 2. So this means you can theoretically take the exam after taking Part 1, but it's recommended to do Part 1 and Part 2 written before taking PACES. This is because the Part 2 written is quite clinical. You don't have as much basic sciences in Part 2 compared to Part 1. And a lot of it, the stems are longer, there's more clinical decision making, so it makes more sense to take both Part 1 and Part 2. Part 2 would prepare you better for PACES. But it depends on your personal circumstances. I would recommend taking Part 1 and 2 written and then PACES. Now, recommendation is to have 2 years of postgraduate experience and to have internal medicine exposure. So to take Part 1, you already know this, because if you're watching this video, you've probably taken Part 1 and 2. But to take Part 1, you need 12 months experience after graduation. So you're probably in your F2, second year of foundation when you take. If you take it early, that's the earliest you could take it. By the time you finish Part 1 and Part 2, you're probably either working in internal medicine or a resident in internal medicine training. So you will have some exposure to medicine, which is really vital for this exam, because you need to be comfortable with eliciting signs, with examining patients, with presenting your findings. In regards to waiting lists, there's a 4-category prioritization system where you're categorized into 4 categories based off of whether you are in training in the UK or not. Now, if you're training in the UK, for example, if you're an internal medicine trainee in your 3rd year of internal medicine training, then you're the highest priority, then you will get a seat straight away. If you're in the 2nd year, you're more of a priority. If you're the 1st year, and if someone the 2nd year applies and your 1st year applying, the priority will go to the 2nd year trainee. From what I've heard from people and my personal experience, I took it when I was in my 2nd year of internal medicine training, and there wasn't a waiting list. If you're not in training, however, or you're applying from outside of the UK, then you might have a waiting time. I know friends that are non-trainees that have applied. Some have faced around 3 months, 4 months. It could be longer, it could be shorter. It depends on cancellations and availability. But if you're not in a training program, prepare to wait for for a month or a few months or longer. So apply early. If you're not in UK training, apply early. I know that other countries as well, if you're, for example, so if you're taking it in, say, this is just an example, I don't know for sure, but I've heard this. If you're in training, internal medicine training in Egypt, for example, and you apply for an Egypt-based exam, then you might get prioritized as well. So local residents also get prioritized. The exam is held 3 times a year. You're called diet. So there's 3 diets. So one is running from January to April, and then April to August, and then September to December. You could get a date anywhere along that timeline. So say, for example, the window opens like 2 months before the diet, a month before the diet. So say if all of the deadlines and stuff are available on the MRCP UK website. So if I apply for the first diet that runs from January to April, I apply, for example, in October when they open, then I could get a date anywhere from January to April. If you need more preparation time, you could ask. I personally asked because I wasn't well prepared. So I asked for a late date, and I got a date in late March. So you could ask, but theoretically it can't be guaranteed. But from my experience and my colleagues' experience, they tend to cater to requests as well. But you're not going to know a specific date until you get it. The exam runs in the UK and also in 16 international centres worldwide. In 16 international countries, some countries have more than one centre. After your application, you get an exam date, and that's based on prioritization. So if you're not a priority, if you're not in training, you might apply for the first diet, but you might get a date in the second diet. So take that into consideration. So let's get into the actual exam. So as you can see, this is the PACES carousel. So you could be thrown into this carousel at any point. So your exam could start from station 1, and then you go along the stations, it could start in station 4, and then you go along the carousel. So you have 5 stations, each are 20 minutes, and then you have 5 minutes break in between. So all in all, that would be 100 minutes of being in the stations and 25 minutes of break, so 125 minutes overall. So a bit over an hour you're going to be in the exam bay. It's going to go by really, really quick. All right, so as you can see, the stations are either one long consultation. So if you look at the purple and the yellow, these are 20-minute blocks of consultations, where consultation stations are basically you have a patient, you take a history, you do relevant examinations, and then you present your findings, you explain to the patient, and then you present to the examiner. All of this happens in 20 minutes. You're allowed around 40 minutes to take your history and examine your patients, and then the rest of it is going to be presentation to your examiner. So I tend to say to take your history in 8 minutes maximum, and then do your examination in around 4 minutes, 5 minutes, relevant examination to the system. You don't have to do every examination in the consultation stations. It's just the relevant one. So if it's a cardio patient, you could do a full cardiovascular examination, and then if needed, you do as needed respiratory exams. For example, you check for bibasal crackles if it was a heart failure patient. So as needed examination. And then I'd spend a minute in the end to just explain everything to the patient, and then you present to your examiner. The other stations, if you look at the combined ones, you see there are 2 encounters. Now it's either 2 examination stations or an examination and a communication station. Now we'll go into these in more detail, but just an overview. Your examination stations, you're basically just doing examination. So no history, no talking to the patient aside from introducing yourself. and asking them to raise their arms or whatever, you're giving them prompts, but there's no history taking. So it's purely 6 minutes of examination. You want to aim to finish your examination in 5.5 minutes, to have an extra 30-second at the end to sort of gather your thoughts. And after you're done with your examination, straight away the examiners are going to ask you to present your findings. The communication stations are either a consultation station, a counseling station, sorry, where you're counseling a patient about a condition. For example, say a patient's been diagnosed with hemochromatosis and they want you to explain what that is, and they have questions that you answer. Or it could be an angry relative or a patient or any ethical scenario or any common communication problem that you see, that you encounter on a daily basis, could really come back on the communication station. So this was just an overview of what the 3 different stations are. But yeah, so it's either one block where it's a 20-minute consultation, or it's 2 smaller encounters. It's either a combination of a communication and examination station, or in your station 3, it's both examinations. This is one of the difficult ones, where it's either cardiovascular and neurology. And these combinations are always the same, so they don't change. All right, so that's an overview. Now let's go over the marking system, just an overview of it. This here, there's a lot of information in here, so don't let that overwhelm you, but basically every encounter that you have, there's 2 examiners, all right? And they give you a score in different skills. So this is for the consultation station. This is the maximum point that you could get, this is the maximum, because all of the skills are examined in the consultation stations. There's 7 skills. We'll go over all of them in details, but these 7 skills are all examined in the consultation station. So you have 2 examiners, both of them give you a score out of each skill, all right? And they give you a score from 0 to 2, 0 being unsatisfactory, 1 being borderline, and 2 being satisfactory. So in this station, for example, each examiner can give you a maximum of 14. So the maximum point you could get in consultation stations are 28. So the scores of both the examiners are combined, and that's your score for that station. Now, have a look. You have each skill: physical examination, physical signs, clinical communication, differential diagnosis, clinical judgment, managing patients' concerns, and maintaining patients' welfare. So all of the skills are examined in consultation stations. That's why consultation stations are very important. If you do well on both of your consultation stations, then you get really good marks on most of your on all of your skills. Now, this is very important to know about the exam. If you fail a station, it doesn't necessarily mean that you failed the exam. What you need to pass this exam is, 1, your overall score needs to be higher than the minimum, and you need to pass every skill. You don't have to pass every station, you have to pass every skill. Now, what that means, we'll explain later. But remember that your overall score has to be more than the average, than the passing mark. And number 2 is you need to pass every skill. Now, I'm just going to show you different scoring papers for different stations. So this is the examination station. As you can see, it doesn't have 2 of the skills. So you have skill A, B, D, E, and G. All right. Now, because you're not talking to the patient, you're not being scored on your clinical communication, and you're also not being scored on addressing the patient's concerns. Again, because the patient doesn't speak to you. So in this station, your total score is 20. There's 5 skills, 2 examiners, so the maximum you can get is 20 in this station. Now the next one is your communication station. As you can see, all the clinical skills are out of this one. Identifying physical signs, differential diagnosis, or clinical judgment is in there, and your examination skills. Those 3 are out, so you're only being examined on 4 skills. The maximum you can get in this one is 16, because the maximum points for 4 skills is 8, and there's 2 examiners, so you double it, the maximum is 16 you can get for communication stations. All right, so this is just an overview of how you're going to get graded. Now, passing rates. This is these next few slides I've taken from the results published for the first diet of 2024. Now, as you can see, the overall, if you look at the last bar graph, the overall passing rate is 49%. So half of the people who took the exam didn't pass. But look at the bright side, half of them passed. So if you prepare well, if you have the right mindset, you can be that half that pass. Okay? You need to be prepared. You need to know how to prepare. This is very important. You need to know what to do to pass this exam. You can be an excellent clinician and fail the exam because you didn't know what they were looking for. Failing the exam doesn't mean now. One of my consultants, when I passed the exam, told me this, and I think it's a really good good point about the PACES exam. Failing the exam doesn't mean you're a bad doctor, but passing the exam means you are a good doctor, right? So it means that you're able to work within the system. It means that you're able to figure out what it is that this exam wants, and you improve those skills in yourself to pass this exam. All right. So if you have a look, this is just different demographics. You see that the UK centres tend to perform a bit better than the international ones. Female candidates tend to do a bit better. Don't know why. I don't intend to analyze this data, but maybe female doctors prepare better for the exam. I don't know. Maybe they're smarter. White candidates tend to do better. So as you can see, UK centres and trainees and white candidates tend to do better. Maybe because they're more used to the system. It's that they studied here and they grew up with this system of examination. Or in international centres, the passing rate is a bit lower, but the overall passing rate is 49%. It's not great, but again, with the right preparation, it's very doable. Don't let this put you off, okay? This might scare you a bit to start preparing, which is not a bad thing. The overall score distribution. Now, this is the overall score that you get for all of your stations. So maximum of 28 in 2 consultation stations, maximum of 20 in 4 examination stations, and maximum of 16 in 2 communication stations. Now, the pass mark was 126 for this diet, and it tends to be close to 126. 126 tends to be the pass mark for most of the exams. A lot of people, from what I've seen, don't struggle to get 126 because some of the skills are not that difficult to get scored well in. For example, managing patients' welfare or physical examination. If you follow the right sequence of physical examination, you'll get a full mark. Or if you manage the patient's welfare, if you're a respectable professional, you get full marks in that. So a lot of people do get marks above the passing mark overall, but what a lot of candidates struggle with is failing one skill. Now let's get into what that means. Now, if you look at the skills, each of these skills, A through G, have their passing marks, right? So you see the passing mark for maintaining patients' welfare is really high. It's because a lot of people don't get marked down on it. So the average tends to be very high. So if you look, the average is actually very close to the full mark. So a lot of people get the full mark for it. Another one is, so that one is one where the pass mark is quite high. The others, the difficult ones, are identifying physical signs, differential diagnosis, and clinical judgment, right? So these three are a lot of candidates struggle with. If you look, the mean score and the pass mark for both identifying physical signs and differential diagnosis are very close to each other, meaning that a lot of candidates barely passed. The mean score is very close to the passing mark. This is the two skills that you should concentrate on, because they're the two more difficult ones. Another one is managing patients' concerns, simply because a lot of candidates forget to ask about patients' concerns. But again, we'll go over that in details later. So again, this is the mean scores for the stations, right? So you can see that the mean score for the consultations are quite okay. What you can notice from here is you can sort of see which ones are difficult ones, right? You see cardiovascular and neurology. The mean score is quite far away. So abdominal, neurology, CVS, respiratory, basically the examination stations. Candidates don't perform that well in. Even the clinical consultation stations, you can see the mean score is around maybe 23, wherein the maximum is 28. You can get a lot of points in those stations, and it's something to really focus on in your preparation. So this was just an overview of the scoring system and the statistics, just to get your head around how the structure of the exam is and how you are graded for it, and to understand the numbers behind why we say you need to focus on certain things. Now, let's get into this. This is very important, guys. I think this is the most important thing in preparation. Understanding the clinical skills, okay? Now, it's very important to know what each of these are and how to prepare for them. So I'll take you through each, starting with physical examination. This is the first skill. This basically means how well you can demonstrate a physical examination, right? How well can you do the steps of a cardiovascular examination? How well do you go through the steps of an upper limb exam? Now, these aren't many. So you've got cardiovascular, respiratory, abdomen examinations, right? These are standard. And then for neurology, you've got 3, right? You've got cranial nerves, upper limb, and lower limb. So 6 examination sequences that you need to learn by heart. Practice till it becomes second nature to you. You turn every patient encounter into an exam station. If you're working in SDEC, you see a patient come in with chest pain, do a full cardiovascular examination. You're doing your ward rounds, try to do 2-3 full examinations on patients, on your partner at home, your sister, your brother, your whatever, your friend, your colleague. Constantly practice on your physical examination skills. My good friend, when we were preparing, said, I know I'm well prepared if I can do the examination backwards, right? So if I can comfortably and without hesitation go through the steps and perform the examination backwards, then I'm confident that I've prepared well. That's because you will get some pressure on the exam, right? There is some stress during the exam, so you don't want to miss something. And one thing that really worked for me is knowing exactly what steps I'm following, especially from the general examination. So how do you look at the hand? What do you look at in the face, in the eyes, in the mouth? You get a lot of this from the Pastest videos, but create your own sequence. Maybe you don't want to do something exactly like the video. Write it down, your sequence, know it by heart, what sequence you're following for every system. Okay, so that's quite straightforward. It's an easy one to get scores in on the exam. Make sure you know it by heart and you perform well in the exam. Before you start, also look around the room. This is very important. There's not not exactly related to physical exam skill, but before you start the examination, have a look around, read the prompt. So just to give you a general idea, when you go into the station, you have a prompt on the wall. So you read the prompt. So examine Mr. Smith's cardiovascular system, or it might give you a prompt saying, Mr. Smith came in with shortness of breath. Please examine the cardiovascular system, right? Go in, look around the room, see if you see any clues, right? So if it's an asthma patient, there might be a nebulizer, or if it's a pulmonary fibrosis, there might be an oxygen concentrator, or there might be clutches around, there might be a wheelchair. Look around, there might be dentures, there might be peak flow meters. They leave stuff around the room as clues. And then have a quick look around the room, look at the patient from the end of the bed to get an idea of what you're looking at. Is this a obese patient? Are they breathless? Or do they look comfortable? So this gives you a general idea. Then introduce yourself to the patient, right? So this is very important. Just an overview before we go through the skills. So yeah, we went through physical examination. Skill 2 is identifying signs. This is the bread and butter of the PACES exam. This is where a lot of candidates struggle. Remember that this PACES exam is bring real patients with real signs. So they're real signs that you have to pick up. And this is basically what this skill is testing, whether you are able to pick up the clinical signs. Now, this is just practice. You need to examine as many patients as you can. Go to PACES teaching at your hospital. If you're in a teaching hospital, ask your colleagues. You most likely have a PACES course or PACES teaching that runs. In our hospital, there was a weekly, on Wednesday afternoons, there's PACES teaching. Very useful. A few of the registrars would pick patients that had signs, and then we would go around in a group, small groups, and you would get a chance to examine patients and present. This is very important. And on your own, go around the wards. What I would tend to do is around 4:30, maybe a month or before the exam, a few weeks before the exam, I would decide to stay a few hours after work just to examine patients. I would go around the wards half an hour before work finishes, go around all the wards, cardio, gastro, resp, neuro, ask the registrars or the residents that were working there, what patients do you have with signs? Write them down, and then either do it alone, or even better if you have a colleague with you, a partner that you're studying with, or a registrar that could supervise you, and you can present the findings to them. So I would go around trying to examine 8 patients, 10 patients, try to find the signs, and then do your examination, present to someone, and then have a look at the notes, see if you find what you found was right or not. So this is very important, guys. You need to get very comfortable with examining patients, with picking up signs, and very important to not make up signs on the exam as well. If the clinical picture, you're thinking of something, but you don't find it on examination, don't make it up. Because if you make something up that's not there, you will get 0 on that station. You'll be failed on that station. So try to practice as much as you can on as many patients. Go around the hospital, look for patients, attend PACES teaching, buddy up with someone preparing. This is very important, okay? And you can do it, especially if you're in a big hospital. There's so many patients. Even if you're at DGH, a smaller hospital, there's so many patients with so many signs. You can make a WhatsApp group as well. Be careful not to share any patient identifiable data, but you could, if someone has a sign, you could say, oh, this bed space in this ward, there's a patient with signs, and you can share with your colleagues. Right, so skill number 3 is clinical communication. This is basically how well you take a history and you explain the findings. This is for your clinical consultations and your communication stations. Practicing in NESTEC is really good. I would try and do it in an exam setting where I would give myself the 15 minutes that I have on the exam to sort of take a history in 8 minutes, examine in like 5-6 minutes, and then to get to talk to the patient for a minute or two about what their presentation, what I think it is, and what we're going to do to investigate this further. And then I would present my findings to the registrar or consultant that I was working with. And I time myself, make sure to time yourself, to try and contain yourself within that time. Because when you say a history taking, that is everything. So from your history of present illness to your past medical, past surgical, social history, or drug history, or you need to ask all of the relevant histories. And you need to get into a habit of being able to do that in time, in 8 minutes. If there's a few things left and you need to go on to examination, you can start examining and asking questions at the same time, especially if you can multitask. I personally can't multitask for the life of me, so I wouldn't do that. I made sure that I asked my questions in 8 minutes and then go on, examine for like 4 or 5 minutes and spend a minute or two explaining to the patient what I think he has and what we're going to do. We're going to admit them, or we're going to investigate further what the plan is. Use ICE after you're taking your history and examination. Do you have any idea what this could be? Do you have any concerns? What are your expectations? Quickly try and go through an ICE, especially the concern is very important. And we'll get to that in the concern, managing patients' concern skill, but using ICE in clinical consultation stations, I find it very useful. Skill 4 is differential diagnosis. This is also one that that candidates struggle with. Now, offer 3 to 4 structured differentials. Now, and using categories is very important. You can use onset or it could be system-based. Now, I'll give you an example of each. For example, a patient comes with a hemiparesis, for example, spastic hemiparesis, for example, and you want to give an organized differential. Now, you could use a time-based, an onset-based categorization for this. So you could say, right, so if this was a very sudden onset, I would think of vascular causes such as stroke or a spinal stroke. If this was more gradual, I would think of, for example, demyelinating conditions, or especially if it's relapsing or remitting, or I would think of traumatic causes such as road traffic accidents or any trauma to the spinal cord. If it was more gradual in onset, for example, I would think of infections, or I would think of space-occupying lesions. So you can sort of make a structured differential based on the onset, or you could base it off of symptoms. For example, a patient comes in where you do an examination and you find bibasal crepitations that are very fine, and you're thinking of an interstitial lung disease. So in your list of differentials, you could categorize it by system, right? You could say this could be idiopathic, it could be connective tissue disease related, right? Such as rheumatoid arthritis, such as SLE. This could be occupational related, such as silica or asbestos exposure, or pets, bird fanciers, lungs, or it could be medication related, from methotrexate to amiodarone, to certain antibiotics. So you could classify it. It could be infections such as undifferentiated interstitial pneumonias. So you could categorize it like that, make 3-4 categories, and that gives a structure. That's very important. It shows that you're organized in your thoughts. Okay, it doesn't have to be 10 differentials, especially because you would run out of time. You can't go into the investigation and the management bit. So keep it simple. Try and categorize. Keep it to 3-4 differentials. Clinical judgment. You discuss investigations and management. So after you list your differentials, that's why we said keep it a bit short. Then you go over how you'd investigate. So, for example, let's give a common example. For example, you get an aortic stenosis, right? So you would give your differential, right? There's 5 pound of murmur, ejection systolic, radius to the carotid, loudest on expiration, loudest in the aortic area. My most common differential would be aortic stenosis. How would you investigate? So always start with the common stuff, common routine stuff. So bedside stuff, like I would do a urinalysis, for example. I'll check BMs. Right? So very, very important stuff to check for cardiovascular risk factors. Then I would do an ECG, and I would send off routine blood, so full blood count, UNEs, liver functions, and a thyroid function, especially if there's arrhythmias. And I would do a jelly scan of the heart. If I find an aortic stenosis, it would depend on the degree of the aortic stenosis. Simply keep it simple, right? So if it was severe aortic stenosis, if you want to show off, you could say if it was the diameter of the valve was less than 1 centimeter squared, or the flow through it, the velocity was more than 40 millimeters of mercury, then that would be a severe aortic stenosis. If it was associated with symptoms, such as syncope or exertional dyspnea or dizziness, or if it was associated with ventricular dysfunction, then I would consider treatment. Treatment would be either open heart surgery and valve replacement or TAVI. And then the examiner is going to prompt you. Right? You might ask, right, so what choices of valves do we have? You say, all right, so we have metallic valves and bioprosthetics. This would depend on the age of the patient and the risk of falling over and being on warfarin. So if it's a frail older gentleman that has risk of falls and its life expectancy is not that much, then I would consider a bioprosthetic valve or a TAVI. But if it's in a younger patient that's fit and well, then a metallic valve can stay in for longer, and they're not at risk of falling and having a bleed if we put them on warfarin. Simple, right? Try to be impressive in your answers, but also don't go on and on about something, right? If you do go on and on about it, the examiner might cut you off and prompt you and ask you a question. But if you do that yourself, it just shows that you're more structured and organized. Skill 6 is managing concerns. Now, use the ICE framework. Always ask about patients' concerns to be assessed in this skill. You don't have to worry about this in the examination stations, but in the consultations and in the communication stations, always ask, what are your concerns? Because unless you ask it, they can't give you points for it. So some candidates fail this simply because they don't ask about the patient's concerns. All right? Please remember this. Clinical consultations, you do your history or examination. When you talk to the patient, what do you think this could be? What are you concerned about, right? Communication, they tell you, I want to be discharged from the hospital, I want to go home, I want to do blah, 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 I need to go, I want to self-discharge today. Ask, what are you concerned about, right? What are your concerns? Why do you want to leave, right? These are very important, not only on the exam, but for your clinical practice as well. So understanding what someone's concern is the root of solving the issue, right? So you need to know, always ask what the patient's concern is. Skill 7 is patient welfare. So ensure safety, comfort, and dignity. If you're respectful and professional, I personally, when I go into the exam room, after reading the prompt, I shake the patient's hand, I introduce myself, I sanitize, shake the patient's hand, introduce myself. Yes, it takes 10 seconds from my time, but I think it builds a good rapport with the patient, and it shows the examiners that you care about your patient, which is very important. And when you're examining, be careful not to hurt the patient. If you see that they're in any sort of discomfort, stop. Or if, for example, when you're doing abdominal examinations, make sure you look at the patient's face for any grimacing or any pain. If you're doing any maneuvers or moving the patient, for example, you're raising the patient's arm to check for a bounding pulse, Always ask, do you have any pain in your shoulder? Can I lift your arm? All right. So ask before doing anything, before putting a stethoscope on them, because before moving any part of their bodies, always ask, always be respectful and professional. Okay, and you would easily get a full mark in this if you follow this. So, all right, so that's the skills. The reason why I go through these skills, it's important because that's where most candidates fail. It's because most candidates fail in either identifying clinical signs or in formulating differential diagnosis and concerns, patient concerns. And so you know what the weak point of the exam is. You know what you need to do. You need to pick up the right signs. You need to present well. Clinical judgment is also a skill that some candidates fail at. You make a reasonable list of differential diagnosis and you ask for the patient's concerns. Concentrate on those 4 skills. Okay. Start early. I prepared 2 to 3 months before my exam and I regretted it. I wish I would started earlier. If you're waiting for a date, you're not sure, start preparing. Go to weekly PACES teaching. Prepare well. Examine real patients daily. This is the most important thing. No PACES course, no PACES teaching is going to prepare you to this exam. You need to examine patients regularly on a daily basis. You need to make it part of your routine. Present findings regularly, especially to registrars and consultants. This is this is very, very important. That text in green is a typo. Be prepared to embarrass yourself, no examine yourself. Be prepared to embarrass yourself. When you're presenting, you're not used to this structure of presenting in such a short time span and to say everything you need to say. So you might say some stupid things or you might pick up a wrong sign, and it's fine. Like, present as much as you can, embarrass yourself as much as possible. If you freeze and you don't know what to say, it's fine. You do that enough in your preparation, you won't do it on the exam. Okay? It's a very high stress environment. So the more you simulate that environment, the less you're going to be stressed on the actual exam. So please prepare very early. Find a buddy that's preparing at the same time. Or if you're someone that prepares doing things alone, do it alone. Go around the hospital, find patients, look for patients with signs, examine them, present to someone. Find someone on the ward, the registrar looking after them, the resident looking after them, the consultant, and say, hey, I'm going to go examine that patient. Is it okay if I present my findings to you? Time yourself, present in 4 minutes like the exam, and let them ask you the questions. And take feedback. Be open to feedback. Don't say, no, that consultant gave me some feedback, I didn't like it, they were being too judgmental. Like, take every feedback you get, right? Take everything. If someone tells you you're too slow, if someone tells you you need to be more empathetic, someone tells you you need to work on picking up that sign, listen to them, all right? Feedback is very important. Regular examination, that's key. Pastest videos. The first thing you should do when you're starting preparation, watch the Pastest videos. It gives you a template to work on when you examine your patients, what to do. Watch with the normal examination videos first, how to do each of those 6 examinations we talked about, right? And then you can go into the case-specific ones, right? They have a video for most of the common scenarios that come back on the exam. I tended to watch 2 to 3 videos a day. And then you could, if you go on to the video additional information, you can find the transcripts for the videos. Download those transcripts. You can put your own notes on the PDF files. And then if you need to review it for later, you could review this transcript instead of watching the video again. I found that useful because watching hours and hours of videos can get a bit boring and it takes time. So I found that useful personally. So it might be something that you might find useful too. Download the transcripts. I made it into a folders for each system. And then I could go back and review them if I needed. For my own use, after I was done with it, I deleted them. So yeah, Pastest videos, they're very good. I'm not sponsored or anything by Pastest at present, but I just personally really benefited from their videos. That's why I recommend it. Again, exam techniques, we talked about this. Can you do it backwards? Practice with everyone and let it become second nature to you. Teaching and courses. Now, this is, I think, quite controversial. Should you go for a PACES course? Now, before talking about courses, join PACES teaching in your hospital. If you don't have it in your hospital, if you have a close by university hospital that run PACES teaching, email them, see if you can join their PACES teaching. A lot of hospitals run weekly PACES teaching, which is very good. There are multiple courses. The more famous ones are Past PACES and Past PACES Ahead. Again, I'm not sponsored or anything by any of these guys, but I personally went to a Past PACES course. All the PACES courses are quite expensive. There's 1-day courses and 4-day courses. I went to a 4-day course. It costs around, I think, £1,600. It's a lot of money, but if you're in training, your deanery is gonna cover the cost, so you can claim it back. So if you are in training and you have time, go for a course. I would recommend, I think it's a good experience. If you have time and money, go for it. You will see a lot of patients with findings. In the Past PACES course, they bring back a lot of patients with a lot of signs. You see a lot of rare cases. I don't know, from like neurofibromatosis. They had like neurofibromatosis type 1 and type 2 right next to each other. They had like heart transplants and more rarer conditions that I can't remember now. But they had a lot of rare conditions. It's about, a lot of times you go around either by yourself or with someone, and you're expected to find the findings and present to the examiner there, to the whoever is doing the teaching. I went quite early in my preparation, which I regretted. I think go 2 to 3 weeks before your exam, because there's not a lot of teaching, right? You're not going there to sit in a room and have people explain things to you. You're basically running around all day from 9 to 5, examining patients and presenting your findings. So if you're not used to it, if you're early in your preparation like I was at the time, you're a bit like a deer in headlights. You're not sure what you're doing, and they can be a bit. I mean, I don't want to say anything controversial, but it's very like structured, and they want you to come prepared to the course, you know. So if you're a bit lost, no one's going to sort of try and teach you and guide you in the right direction, because there isn't enough time. There's so many people and so many patients to see. So it's better to go very close to your exam, that you're ready, and it's sort of like a lot of mock exams that you do along the way, and they do a mock exam at the end of the course as well. So it's really good. I personally, when I left the course, my confidence was much less than what it was before doing the course. And a lot of that was because it was very early in my preparation, but it really scared me to start preparation. I felt, well, I'm really not ready for this. I need to start preparing. So I think prepare well, and then 2 to 3 weeks before your exam, try to book your course there. I would recommend it. If you have time and money, go for it. Can you do it without a course? Definitely. I don't think it's makes that much of a difference, but it will make a difference. So yeah, that's that. Mindset really matters, guys. Stay positive. Remember that you've accomplished a lot already. You've gotten into medical school. You've passed medical school. You've passed your part 1, probably passed your part 2 too. You've probably gotten into training, or you're working as a non-training in internal medicine. You've done so much already. and it's just a matter of time before you pass this as well, and add that MRCP title to to your list of credentials. So yeah, confidence and consistency will carry you, and I wish you all the best in your preparation. Please like and subscribe if you like the content. On this channel, I do a lot of MRCP preparation, exam preparation, some medicine stuff as well. I try to explain some common topics or things that are a bit vague and difficult to understand. I try to simplify them in educational videos. I also do some career progression videos and lifestyle videos. So if you like the content, like the video, please, because it means that more people see it, and subscribe to the channel. On the screen, I'll put a few of my videos from other topics that you might be interested in. But yeah, that's it. I hope this was useful, guys, and best of luck on your paces. If you had any questions, please do leave it in the comments below so that others can see it and benefit from it as well. And I will get back to you as soon as possible.